Hi everyone. I'm sure that people are still rolling in and will over the next couple of minutes, but due to our tight timeline over this lunch series, I'll get started. My name is Mandy Ashley. I'm the Executive Director of the Aurora Health Alliance. Welcome to our virtual behavioral health series. In this series, we are focusing on vulnerable populations during COVID-19. This series is sponsored by Colorado Access and Signal Behavioral Health. We are so grateful for their support. And of course, I need to throw in, if your organization is interested in joining as a sponsor, please let me know. This is the first of 4 events in our series. Today, we're focusing on cultural disparities. The next 3 events are the next 3 Wednesdays, where we'll focus on seniors and substance use disorder, excuse me. We've left the topic for the 4th and last event open in order to give you all a chance to give feedback on a vulnerable population you feel it's important to focus on. If you have suggestions for that, you can drop a note in the chat box at any time or email info@aurorahealthalliance.org. Following this event, we'll be sending out a short evaluation to measure the success of the web series with the who is our Colorado Refugee Health Coordinator, wanted to join us today, but was unable. But she did provide us with guided questions to think about when it comes to COVID-19 and cultural disparities, along with a list of translated materials. We'll put those on our website and drop them in our newsletter. The website is aurorahealthalliance.org/HA-behavioral-health. Okay, time is tight, so I'd like to go ahead and introduce our 4-member panel. Time for questions at the end. If you have a question throughout any presentation, you can enter that into the chat function and we'll monitor that on our end and ask those questions. Master of Social Work with the Methodist Hospital. Next, Sarah Jackson, Executive Director of Casa De Paz. And finally, we'll be hearing from Dr. Cleveland Piggott, who's MD, Master of Public Health, Assistant Professor and Director of Diversity and Health Equity for the University of Colorado Department of Family Medicine. Okay. Jan, if you just tell me next slide, I will put myself on mute and advance them for you.
That sounds great. Hello, everybody. You can see before you that the topic I'm talking about is health disparities, COVID-19, refugees, and mental health. So you can advance to the next slide, please, Mandy. We know that refugees are one of the communities known to experience health disparities even prior to the pandemic. It's likely that they're being disproportionately affected by COVID-19 also, but there is insufficient in this across Colorado and in the country as a whole, and there is data showing this. But there are not categories of data which are refugee specific, nor which offer information regarding more finely categorized ethnic groups. However, there is some data to suggest that refugees and limited English speakers are being significantly affected during the pandemic in Aurora. Since Aurora is considered one of the 5 most diverse cities of its size in the country, this should not be surprising. University Hospital recently reported that 40 to 55% of the patients who they tested for COVID. The Artist Family Clinic in Aurora reports in the Sun-Times that 45% of the refugees that they have tested were positive for coronavirus. And we also have clinical observations from the front lines, such as a dramatic increase in referrals to our clinic related to COVID-19 and requests for assistance from other organizations in addressing refugee needs during the pandemic. We are seeing a lot of factors likely to contribute to increasing the negative impact on refugee communities, such as many are working in jobs with greater risk of exposure, both during and even before the pandemic. For example, many refugees work in meatpacking plants, JBS being one of the main ones, and as you've been seeing on the news, it's now a federal mandate that they continue to go to workers. We know there have been deaths of refugees working in that plant. Also, initially, many refugees find work in low-paying jobs, which were lost during the pandemic, such as working in restaurants or in hotel laundries. They are currently finding jobs, many of them, which are available to make ends meet, which involve greater risk of exposure, such as working as grocery store clerks or cleaners at health facilities. Their housing situations can be crowded with large numbers of family members in close proximity, making quarantining difficult. Low literacy rates in some communities make reading even the limited translated health information not possible. Traditional cultural remedies are being tried by some instead of accessing testing and getting medical treatment or diagnosis. And there are fears and mistrust for some of hospitals and medical services based on historically bad experiences overseas or here. In addition, we've heard of some community members not seeking treatment even for seriously ill family members due to fears of them being separated from those family members should they be hospitalized or if they die. Some testing facilities and medical settings are not prepared for increased numbers of non-English speaking patients in terms of responding to language and cultural needs, which is ripe for misunderstanding and increased anxiety for both the medical providers and refugees alike. They also are experiencing difficulty, as are many people, accessing benefits and understanding the federal and state guidelines. For instance, misunderstanding the stay-at-home order. We, as one example, had a family that thought that they were not allowed to leave their house at all, and so 5 of them were crammed into a tiny apartment, not leaving for groceries or for exercising. There's also a lack of awareness of what benefits they may be eligible for, which is complicated even for Americans to figure out. And many can't navigate the process of filing for benefits with their difficult multi-step English instructions, leaving some in situations of food shortages, depleted finances, and inability to pay rent or other bills, and fear of eviction and returning to a homeless state akin to their previous refugee experiences. We and many others have been trying to assist with these obstacles, but it is very time-consuming to do this, and there is currently a piecemeal system and versus a more coordinated effort on how to assist refugee families in applying for benefits so that it's not taking time away for providing other important mental health services. In terms of our provision of mental health services, I think we can go to the next slide. All of these factors for us mean that mental health needs of refugees start with addressing basic health needs as opposed to it being possible to focus solely on mental health issues if you can't feed your family, you're not going to want to talk about other mental health issues. Our team consists of behavioral health providers and health navigators, speaking a total of 17 languages. Our navigators come from the primary communities of refugees resettled in Aurora, which allows clients to contact someone who speaks their language and understands their culture and decrease barriers to accessing care. Navigators are often on the front line of our mental health approach, assisting in solving issues surrounding accessing resources and connecting to various services before situations escalate into larger mental health and medical issues. During the pandemic, we have adapted our service model. We're doing active outreach to community members to provide health education on COVID-19, to assess basic and mental health needs, and to listen for other community members in need who are not our clients and may not have access to needed services. We are using a mental health first aid approach in part, which helps train community members on how to recognize others in the community who are also struggling and how they can access help. We're using a disaster mental health model also, which includes psychological first aid, involving providing mental health assistance while taking care of other basic needs, such as helping to stabilize the situation and provide safety in the midst of a crisis. Aurora Mental Health, as I'm sure many other organizations, switched literally overnight to a telehealth model, which in our clinic has mostly meant communicating with clients over the phone due to the limited internet and computer access that many refugees have. On the positive side, I can report that this dramatic shift in service delivery has been better accepted than I might have anticipated. Staff and clients alike just had to jump in and make it work pretty much overnight. I like to reframe it and call it concierge service that we're now offering, since we're bringing services to clients in the comfort of their own homes. We do, in fact, have fewer no-shows, as where are any of us going anyway? And if someone is not available, we can call somebody else who is likely to be and may also need help. We've seen a great deal of appreciation from refugees on being checked in on, and often more frequently than we might usually, because of constantly changing situations which are evoking anxiety in refugees. And as this pandemic has lasted longer, we're seeing increased sense of isolation for some community members, and they appreciate more frequent contact. It has also spawned the use of technology which is adapted to various communities. For instance, we're trying different platforms that certain communities are more familiar with, such as using WhatsApp for some of the refugee communities that can use that versus Zoom. We're also finding it has created complexities, such as ensuring the privacy of conversations, which may clash with certain cultural norms involving having other family members just start joining in on the conversation. We had one instance where we're saying hi to our client, and then suddenly the husband pops in and says, well, aren't you gonna say good morning to me also? And then establishing what is culturally appropriate for that person.
Dan, we have just a minute or two left for you.
I'm almost done.
Okay.
There are also the complexities of not being able to see people, so we have limited body language, or it's more difficult to gauge people's emotional state over the phone. And for refugees, this is one more trauma on top of the others that they have by definition already experienced. We are providing social support circles in different languages that are giving information to community members and then also responding to their needs. And then finally, we're working at a systemic level, both at the metro-wide and state level, with other community partners to solve systems issues, Like, how can we get a more systemic and efficient way to get people benefits for which they qualify?
Thank you so much, Jan.
Sure.
If you could send me, for our audience, we'll do a follow-up email, just a place to find these resources or to connect with your organization. If you're open to that, I think that'd be a nice
Sure.
thing for us to do. Okay.
Sure, I'd be happy to.
Okay, perfect. Thank you. Okay, up next is Ashley Roman.
Hi there. So my name is Ashley. I'm currently at Health One. I do evaluations in the ED, telehealth, to establish if people meet inpatient mental health criteria. And today I'm going to be talking about health disparities in the African American community. During the time of COVID-19, a global pandemic, it's really put a spotlight on health disparities that have long existed. So these are disparities that aren't new, that aren't just popping up. These have been around for a while. We're also reinforcing the idea that disease isn't just biological, but also sociological. So in addition to the elderly and immunocompromised being vulnerable populations, we're also finding out that race can be a vulnerable population as well. So statistics have shown that from 1980, African Americans have experienced the highest death rates in 14 of 16 leading causes of death. Higher rates of diabetes, hypertension, and obesity. And these health conditions place these folks at higher risk of mortality because of COVID-19. We must ask ourselves, why is there a higher rate of diabetes, hypertension, obesity, among other things? Or if it's not just because of the color of our skin, we're kind of finding out that there's several different factors, such as access to care, different cultural barriers, economic stability, physical environment, education, food community, social content, healthcare system, and understanding that there's also a racial bias in the healthcare system. We also know that food desert exists. Some communities have easier access to tobacco and alcohol than they do healthy food options. We know in some communities there's still lead in the homes, and if we think about Flint, Michigan, who didn't have clean water for the longest time. So we can kind of understand these barriers. So if we want to understand it more, when did this kind of all start? Research has coined a term called the slave health deficit. It pretty much validates that there's been years of discrimination. We know that there's unequal treatment and injustices in healthcare. We know that women of color are 3 times more likely to die from pregnancy complications than their white counterpart. Why is this? Research has found that poor health of Blacks is directly related to the institution of slavery and racism. We found that Africans who've been isolated from other indigenous disease during the transatlantic voyage were now being intermingled and exposed to things such as smallpox, yellow fever, the flu, and this compounded with the inhumane treatment and unsanitary conditions on the voyage just paved the way for how it is now. We know that slaves during this period would be subject to a lifetime of little to no health care and were forced to live in unsanitary conditions that most likely created the foundation for the poor health status and outcomes still present today. Something that also used to be universally thought to be true was called the great chain of being. So this described Blacks as being derived from apes, so as lesser than. We know that during this time that Black physicians were excluded from the American Medical Association, and as a result, there was a shortage in Black doctors, which we still see today. They did end up creating their own National Medical Association. So we can kind of understand how the problem started, what created it, and now we have to think about what kind of challenges we see present day. Researchers have also found and coined a term called stereotype threat. What this means is patients become worried their provider believes the untrue stereotype, and which in turn affects care. And they found that even if the provider doesn't have negative racial stereotypes or racial bias, even if the patient believes that they do, it automatically creates a distrust of the system, underreporting of symptoms, and just generally lying about their health history. And that could be mental health and their physical health, right? They're not going to report that they drink excessively or things like that. And so what are the solutions that we can use with kind of understanding where the problem starts and why it continues to be present today? Obviously, in a perfect world, we would want to eliminate racial discrimination in healthcare and health research. And in the times of COVID-19, people have talked about a recovery bill that I think would actually be very helpful, that would ensure people make livable wages, has access to sick leave, adequate childcare, rent forgiveness, and access to appropriate health care. We know that if people don't have access to sick leave, they're going to work when they're sick and getting everybody else sick. If you don't have adequate childcare, you're at risk for losing your job. If you don't make livable wages, obviously that's a whole problem in itself. Rent forgiveness. And we're finding that healthcare being linked to your employer is difficult in the event that you do lose your job. A lot of people are out of healthcare. The government did kind of do a good job. They did extend the deadline to apply for Medicaid in the event that you did lose your job until April 30th. So that was something great. And then something small, but more people of color providers. Studies have shown that people feel more comfortable when your provider looks like you. Another solution would be providing written information, clearly written information and instructions. This is why you take your medication. This is what happens when you don't take your medication. This is what it's for. When I was a therapist at Aurora Mental Health, I worked with clients who were considered high utilizers. So that meant they were going to the emergency department instead of getting their needs met by their outpatient provider. And a lot of them, and even doing evals now in the hospital, I hear a lot, oh, I stopped taking my meds, which can be almost worse than continuing. Not really understanding the effects of what happens when you stop taking your meds. What happens, what is the lasting effects of this disease going untreated? Making sure the patient truly understands. Also, removing barriers to care, such as late policies being dropped from the practice. Again, as a therapist at Aurora Mental Health, working with people who are high utilizers, I can't tell you how many clients I had that would say, I was dropped from my doctor's office because I was late too many times, or I no-showed too many times. I'm a firm believer that one size does not fit all, right? So you don't have to hold everybody to the same standard. If you have one client or patient that is good about making their appointments and they miss one, of course, obviously do what you need to do. But for someone who doesn't have reliable transportation, relies on family and friends to get to their doctor's appointments, or has significant mental health needs, they're going to be a client or an individual that's more likely to miss their appointments. When we don't want to put more barriers to them getting care, so maybe we could be more lenient when it comes to how many appointments they miss, or do some sort of like point system where points fall off. Sorry, that something popped up and it distracted me. One clinic that I used to work with had one day that would do drop-in hours. So this is good for those sort of patients and clients who can just go and they don't have to worry about being on a time constraint. And then another thing that could be an innovative solution would be rewards for making appointments on time, or rewards for making a certain amount of appointments. I know a grocery gift card can be a really big incentive for individuals. And then finally, I wonder if a change is needed from the traditional model of mental health and a change is needed from the traditional model of mental health and physical health. So I wonder if we should be more community-based. It's shown that if you're willing to meet the client in the community in their safe space, you're going to build a rapport, and you're going to make it so you've built a rapport where they maybe can start coming into the office. But I think it's difficult to expect an unconventional or a non-traditional patient to follow a traditional model of going into an office, getting a therapy session for 15 minutes when they don't have much free time? Are we able to meet them where they're at, provide case management services and therapy in a car where we help take them to an appointment? I know some of the best therapy I've ever provided has been in the car. And so, yeah, I have some websites that I've used and sources. So if anybody's interested in that, I can certainly email you that. But that's it.
Perfect. Thank you, Ashley. When you were speaking, was writing down the acronym SDOH, Social Determinants of Health, which is another interest group for that Aurora Health Alliance. And it's interesting just how all of this intersects.
Oh, it totally does. Yeah.
So thank you so much. Next up is Sarah Jackson with Casa De Paz.
Hi. Thanks for having me today. I was just going to give a snapshot into the reality that our immigrant friends are facing while they are detained during this pandemic. So currently, GEO, which is located off of Colfax and Peoria, and it is a for-profit prison that contracts out with ICE to detain immigrants. A lot of the immigrants in this detention center are asylum seekers who have just recently crossed the border seeking asylum and then were transferred to this particular detention center, although folks can be transferred to a number of detention centers all across the country. There's really no rhyme or reason where they end up. Some of them end up here in Aurora. And then also folks are detained in this detention center who have been living in the United States for 5 years, 10 years, 20 years, and then were arrested by ICE and put into a detention center where they're awaiting their immigration hearing in front of their immigration judge who will determine their fate. If they win their case or they're able to be released on bond, or if they've been denied and ultimately will be deported to their country of origin. So currently, for about a couple of months now, ICE has suspended all in-person visits all social in-person visits to the detention center. So that means with Casa De Paz, we run a visitation program where we spend time with detained folks. We're not social workers, we're not psychologists, we're not lawyers. We're simply a friend to remind them that they're not alone and there are folks who care about them, and just a link to the outside world, because as you can imagine, detention is a very isolating experience. So we have shifted from our in-person visits, since we're not able to do that any longer, to a pen pal program where we can write people in the detention center. We also have been putting money on people's calling card accounts so they can call out. To make a call while you're in detention costs money, and oftentimes folks don't have the money to put on their calling card. And so even though ICE has suspended in-person visits, they haven't supplemented that by any means by allowing free phone calls out. So that is even further isolating someone in detention. Most, if not all, I haven't updated myself today, but most of the pods in the detention center, the pods typically can hold anywhere between 60 to 80 detained immigrants at once, and it is like a prison, so there are cells where anywhere between 4 to 8 immigrants are in, and but typically in your normal world, the open area is open throughout the day, so folks can leave their cells and they can be out in the main room where there are chairs and tables and TVs on the wall that you can watch. There's no access to outdoor time. They have an adjacent room that opens up and there's a basketball hoop. You can play basketball in a bar where you could do like pull-ups, but it's not outdoor time. So that's a typical experience in detention. But now that they've gone under quarantine because staff members have tested positive, as well as ICE officers and a judge, I believe. They've gone down to a lockdown system, so now detained immigrants are held in their cells. We're getting different reports if it's 2 people to a cell. Some pods, they may have 4 people to a cell, so that it's literally impossible to do physical distancing. So not only are they in a detention center, now they're in their cell, typically 23/7, so 1 hour a day. They're able to leave their cell and go into that main area where they used to be able to congregate. And 8 to 10 immigrants are released every hour into the main part, and so they can just sort of rotate through. So what we're noticing is that there's a definite rise in the levels of depression and anxiety for the folks who are detained. They are now even more tormented by their by what is going on in their minds. Most of the folks that we are in contact with through our visitation program are asylum seekers who have escaped torture or, you know, very traumatic experiences, near-death experiences, or watched their family members be murdered in front of their eyes and then they fled. And so now a few of our friends are saying, you know, all I do now is lay on my bed all day on my back, and those scenes are flashing through constantly. And so as you can imagine, the morale is declining on a daily basis, and a lot of our volunteers who are part of the Pen Pal program are not equipped really with how to accompany someone who is potentially speaking of hurting themselves or wanting to end it because they don't see any end. There is a group in town, the Rocky Mountain Immigrant and Advocacy Network, and they filed a lawsuit against GEO to sued them for the release of 14 immigrants who are particularly vulnerable for contracting the virus. For example, there's a lady who's detained who literally has 1 lung. So if she gets the virus, that's very dangerous. Within 24 hours, 8 of the immigrants were released, and they happen to be 8 women who are transgender and all HIV positive, so they were at higher risk as well. But we haven't seen nearly the amount of people who should be released. And there was a study that came out yesterday by ICE that said across the country there are about 40,000 immigrants in these detention centers, and they've tested a whopping 700 out of 40,000, and out of those 700, over, I think it was 350 or close to 400 tested positive. So we can imagine what that can correlate to. And testing obviously is not being done widespread in this detention center. So when immigrants are released, if they do win their case or they're released on bond, which it is still happening, our volunteers are picking up folks who've been released. We have protective equipment for them, masks and gloves. We also have a 1-page handout that we're giving to everyone who's been released because we don't know what's been told to them in the detention center. And we also know that some of the precautions that the detention center has been telling us that they've been taking to protect not only their staff, but also the detained immigrants, they're just literally not happening. They said that they've implemented taking people's temperatures before they come to work. So at the front lobby, before you pass into the doors of the prison, you're supposed to get your temperature taken. And one of our volunteers witnessed a guard taking the temperature of an employee, and the temperature came back as 92.1, which clearly is not a correct reading. And the guard said, whatever, just go, and he let him in. So we're very, very concerned about the spread of the virus in the detention center and what is not being done for folks. But on the on the other hand, when folks are released, we are still offering our post-release support services. So we're picking up folks. We've partnered with a couple different nonprofits in town, well, actually across the country too, to provide plane tickets so that they can get home as soon as possible. And then we have all the normal stuff that we typically provide: food, backpacks, a ride to the airport. We get everyone through security, get them to their gate, and are trying to provide as much information as possible, because a lot of people are not being given any quality information in the detention center. Someone in the chat mentioned, is there anything we can do to help? Yeah, there are a lot of ways that volunteers can still be a part of the CASA. We're all volunteers, we're, including myself. We all have our day jobs, and then we volunteer our time because we want to treat our detained friends with compassion and dignity like they deserve. And so on our website is, I'll just put it in here, Casa De Paz, Colorado.org. We have remote volunteer opportunities, such as sewing masks and sending them to us so that we can give our friends a mask when they're released. And then we also have on-site volunteer opportunities where you can make meals for folks. You can help pick up people who've been released and make sure that they get the necessary next steps for them to get home to their families. Most of the folks that are released from this detention center have friends or family or sponsors somewhere in the States that they're just trying to get to once they're released. And so there's a lot of ways to connect. Okay, I'm done. Sorry, I talked too long. I'm done.
Thank you,
Thank
Sarah.
you, Sarah. Thank you, Sarah. I'm going to jump in and say thank you, because I think we are all looking to recovery options, and we are living crisis mode, and we need to be looking to recovery options. So to that, I'm going to look to our executive director. So Mandy.
Thanks, Mariana. Our last panelist is Dr. Cleveland Pickett, with the director, or who is the director of diversity and health equity for the Department of Family Medicine. And remember, if you have any questions for any of the panelists, you can drop them in the group chat, and we'll try to get to those before we end. Thanks.
Good afternoon, everyone. I'm really honored to be here to talk about such an important topic regarding behavioral health and cultural disparities in COVID-19. I also wanted to echo all the great points made by the panelists, and I think another thing that wasn't mentioned that you can do for Casa De Paz is donate. I think they do great work, and I'm proud to say that I try to donate to them when I can. As a physician, this is the first time I've seen my fellow healthcare providers scared. They're scared about their health, the health of their families, and the financial sustainability of their practices. We're also really, really worried about our patients. As other panelists have already mentioned, and as a person of color myself, I especially worry that this pandemic is going to exacerbate and reveal many of the health disparities we see in communities of color because of systems of oppression and racism leading to these disparities. There's clear data that there's an overrepresentation of Black and brown people with chronic diseases in prisons, unemployed, uninsured, and experiencing poverty. So any pandemic, any disease process that affects people in those groups will disproportionately affect people of color. We're slowly seeing some national data revealing some of these disparities. As Jen mentioned, there's been several national stories showing overrepresentation of people of color getting and dying from coronavirus in several cities across the country. And in Colorado, we're seeing similar trends, though the data is really incomplete. Arapahoe County, one of the most diverse counties in Colorado, has some of the highest rates of coronavirus deaths in the state. At University Hospital, in addition to higher testing we've heard about in the refugee population, 75 to 80% of people admitted for coronavirus, the sick of the sick, are people of color, and about 30 to 40% of those admitted have limited English language proficiency. Now, if we're thinking about the mental health toll, you have a large portion of our community scared for many reasons. They're scared of catching coronavirus because they have a chronic disease. They're scared about being racially profiled for wearing a mask in public, the stereotype threat that Ashley mentioned. They're scared of losing their job, and so on. All these lead to stress in many people, grief, depression, anxiety, and even trauma. Though the healthcare profession has been creative in coming up with solutions like telepsychology and telepsychiatry, people who have lost their insurance or don't feel comfortable with these technologies aren't getting the support that they need and deserve. As a healthcare provider, I think it's important we continue to measure and give voice to these disparities that we see in our community. I also think it's important that healthcare professionals be proactive in reaching out to the communities we serve and not just expect them to come to us. Because right now, they're scared to come to us. A lot of clinics are doing a great job. At our clinic at AF Williams Family Medicine, we're located in Stapleton on the border of Aurora and Denver. We're a little bit behind, but we're trying to do the best that we can of being proactive. We're starting some new initiatives where we're going to look at people who previously screened on some of our social determinants of health screener, the SDOH, for loneliness, and just call them and make sure that people are doing okay and offer them a visit with either one of our psychologists or one of our providers, or just give them resources or let them chat for a bit. We're also reaching out to all our patients above 80 to check in to make sure that they're doing okay. As a member of the community, I want to encourage everyone to reach out to their healthcare providers if they have any questions or concerns about their own well-being. We're happy to help. I also think we need to be self-aware of how we're managing our own stress. There isn't a lot of great data to support this, but I think as a person of color that many people of color show stress in different ways, and you don't even realize sometimes how stressed you are until you can't handle it anymore. So checking to see, are you using substances like alcohol, marijuana? Are your sleep habits changing? Are you withdrawing from your loved ones? Are you having more mood swings? Are you doing things to know that'll improve your mental health, like exercising regularly? This is an incredible tough situation, will be from an unknown amount of time. I believe we're all incredibly resilient individuals, but it's important that we come together and support each other. And if we're struggling, I want to encourage us all to not be afraid to ask for help. As Pobby said in Frozen 2, when the future is uncertain, all one can do is the next right thing. Thank you.
Thank you so much. Now I'd like to open it up for questions. I do know that Molly Markert with Colorado Access put some information in the chat on Colorado Access having capacity to help people on Medicaid benefits, and she generously put her contact information on there. So if anyone wants to contact her, that's a great resource. Okay, we'll share the information that we requested from panelists, or if you have any other information that you'd like for us to either post on our website or share via email for the people that registered, send them my way. It looks like we had one question come in. Are crisis standards of care guidelines outdated, and do you think they need to be rewritten in order to be more culturally competent? I certainly cannot answer that question. So,
can you repeat it?
Yep, and it's in the chat also. Are crisis standards of care guidelines outdated, and should they be rewritten in order to be more culturally competent?
And I would love for other people to jump in. I always feel that we should always kind of revisit our standards, right? There's always new ways to be culturally sensitive and to kind of, there's always new ways to be culturally sensitive. I probably would say, yeah, they're probably outdated. I know that it's easy to kind of be in the crisis world and kind of do what's always worked, but things change, and I think that we kind of forget that, and we kind of forget how to be sensitive and kind and ask questions in a sensitive, loving way. So sure, yeah, I definitely agree with that. I don't know, maybe somebody else has something to add.
So for those of you not familiar, crisis standards of care are essentially enacted by the governor during a crisis, which sort of allows us to do things that are maybe not what we would normally do in our practice. Who do we prioritize, things like that. The crisis standards of care they're reasonable, but I think if you talk to many different people and get them in a room, you might not say it's fair, in addition to the fact that I don't think health equity was input in those standards as much as they should be. And it definitely potentially undervalues a lot of groups of people. Plus, how do you take in the systems and years of racism into account? If you're saying that you're not going to give a ventilator to someone because they have a chronic disease, well, then you're going to unfairly affect people of color. Should people of color or people with disabilities or other factors get bonus points when you're calculating things because of systems of oppression? These get into really complicated ethical questions that I think we always need to have this discussion about, and there's nothing that's truly perfect or works well for everyone.
Can I also say something not about that question, but with the question that came previously, Mariana asked if there was anything we can do to help. And I just responded with my typical answer, but now I'm thinking through the lens of who is in this meeting. And so there is also an opportunity to support our volunteers who are in this pen pal or video or phone call program that is replacing our in-person visits, because I think that what we've all heard today is this is having an effect on everyone's mental health. And so it would be nice to have some more additional resources to support our volunteers so they can understand how to navigate. Oh my gosh, I said I wasn't going to use the words navigate, pivot, unprecedented, and I just said navigate, but how to navigate through this time. So if anyone is interested in that, I am more than happy to chat as well. And on our website, you can find my contact info as well.
Perfect. Thank you. Thank you all so much. Lunchtime series means we're short on time. As always, thank you again to Colorado Access and Signal Behavioral Health for sponsoring. Our next event is next Wednesday. You can register on the website listed on this slide. Thank you to our panelists, and keep up the good fight.
Thank you.
Thank you all.